These stress tests. In your book, they have the sharp pursor and then the transverse ligament stress test. Use that term loosely as a stress test. So if the transverse ligament is torn, when you CV flex, the C1 is able to translate forward. Right? So this is the main ligament that's going to check that. Oh, sorry. Here's your dens. Here's your transverse ligament. So if this translates forward, that's your spinal cord. If this translates forward, what's going to happen? Yeah, the dens is going to smack into the spinal cord. All right? So that's not good. No, it's not, but that is the major structure. That when they transect that, they do see a fair amount of translation that does happen. So that's why this is considered the test for that. Now, when that happens, what do you see? If you get pressure of the dens on the spinal cord? Well, it doesn't go that far, and your higher, your breathing center is going to be higher up, so you're going to be okay that way. But what you are going to get is you're going to get quadrilateral paresthesias. All right, it may not be painful because you're not going to leave them there long enough for it to start to stimulate pain sensors, but you pretty quickly you're going to get quadrilateral paresthesias. All right, because of the tracks that you're hitting. So what you do is you have the person sitting there and you say, okay, you're just going to start to let your chin drop down towards your throat, and go ahead and make sure they CV flex. If they're all the way CV flex, that's it. They don't have to CS flex. And then you see, okay, how are you feeling there? Are you getting any symptoms? And what you want to do is ask them if they're having any symptoms. You want to say, okay, are you feeling tingling in your hands and your feet? Because then they start going, oh my God, I'm feeling tingling in my hands and my feet, and it might, change the validity of the test. But if they start to say that, then you're like, ooh. Now, the next part of the test is you come on to C2, okay? And what you're going to do is you're just going to gently stabilize the neural arch of C2, and you're going to give a bit of a posterior translation of the head. It's a straight translation, so that what you're doing is you're actually translating the head and C1 back on C2. So if C1 slipped forward when she flexed, and you stabilize, and you're pushing back, and since she's flexed forward, it's this way, right? So when you do that, if you feel a clunk, you feel movement, and they go, oh, thank you, I no longer have my quadrilateral paresthesias, and if they say that, that's kind of weird too. But if they say the tingling is gone, then you bring them back up. This is called the relocation. You put a collar on them, and you call the emergency room. Okay? Because that means there's a significant instability that's happening there. Right? Now, the modified version, they have them just upright like this, and you see the picture of just a push straight back. And if you get that clunk, then it's a positive. But the traditional test is a relocation test that when you flex forward, they're getting their symptoms, and when you do the posterior translation, it reduces their symptoms. That's the traditional test. The test has been validated for patients with RA. And the reason is the RA, it starts to create deterioration, and then when they get that translation, they get the quadrilateral paresthesias. That's where it was originated, that's what it's been validated for, but we use it as a screening stress test that maybe it would pick up on some gross instabilities happening there as well. All right, but it's not as valid for that purpose. Okay, the next step is to say, okay, what happens if I induce that translation? So maybe in sitting, as she flexes forward, her muscle control is controlling everything. She doesn't have a transverse ligament, but things are under control, so she's not getting any symptoms, and when you try and relocate, you're not getting that clunk. So what you do is you come in and so that's the modified sharp pursor test. So what you do is you come in, and this is in Dutton. I just didn't do a slide for it. Sorry, I didn't realize I didn't do that. And you cradle the occiput in C1, so the fingers are behind C1. Okay. And then you're just going to do a straight translation up. Okay. Now you're going to watch her. You're going to look for any signs that you're seeing, any cranial signs that are happening, and you're going to ask if she has any symptoms. So if we do this and she starts to get quadrilateral paresthesias, then that's considered a positive. If she starts to get any cranial symptoms, then that's considered a positive. As you're lifting up, you have the weight of the body and the weight holding things down. All right? Do you do the counter pressure?
Thank you.
Need this one? Okay. That's one version. These are different schools of thought. All right. So some people just do the sharp pursor. Some people feel this isn't as valid. Some people do it just with the lifting. And then the final way where it pushes it to the end is you come in and you perch on the front of C2. Okay, so now I have my fingers on the front of C2. You want to kind of get around the SEM. I'll help the SEM move around. Perch on the front of C2, and then you're going to do this kind of movement coming up. You okay? Mm-hmm. And you're watching for any cranial symptoms. Okay? So essentially I'm stabilizing C2, and then I'm using my hands and I'm doing this. Okay? And I'm doing anterior translation, a straight anterior translation of the occiput and C1. Okay? Be careful with your anterior pressure on C2 because it's not the most comfortable thing in the world. And then you come forward and then you hold it for the 8 to 10 seconds looking for any cranial signs. Okay? The other one I'll just show you is not that. And I'm sorry, I didn't realize I didn't do pictures of these. I stole some of these slides from Dr. E and then I didn't add the button pictures. So what you can do is the traction. Okay, so you're going to do the traction, you're going to stabilize, they're out of the way, stabilize C2, okay, and then I'm going to go into a little bit of flexion, and then I'm tractioning, so I'm essentially just pulling the occiput away from C2. I'm watching the eyes, I'm looking for any cranial signs that are going to happen here, okay, and you hold it for that 8 to 10 seconds. Alright, so it's similar perching as the alar ligament, but instead of doing the side bending, you do a little bit of flexion and a distraction this way, and a counter pressure pushing C2 down, so you're essentially separating C2 on the occiput, stressing the tectoral membrane, and looking for any cranial signs, VBA signs. Okay? Okay, try those.
Can you just